Good morning. Today's class is about CSF analysis. So I'm going to talk about first what is cerebrospinal fluid, how is it getting formed and absorbed, and then next I'm going to tell about what are the indications wherein we do a CSF analysis, and then I'll talk about how to perform how to get the cerebrospinal fluid, and once we obtain the fluid, what are the various investigations being done and the interpretations of it. So this is going to be the overview of the class today. So let's go into the topic proper. So cerebrospinal fluid is, first of all, let's understand what is the cerebrospinal fluid, okay. So this is a fluid which is seen throughout the, covering the brain and the meninges in the subarachnoid space. The main function of the CSF is that it acts as a shock absorber because the whole of the brain and spinal cord lies surrounding a fluid, okay. So this acts as a shock absorber, and also it provides nutrients to the brain and spinal cord and removes all the waste products from it by correlating with the venous sinuses, okay. So that is the main function of this cerebrospinal fluid. Now this is a cut section of the brain where we can see this is a cerebrum, this is cerebellum, this is a medulla oblongata, these are the ventricles, this is the third ventricle, this is the fourth ventricle, this is the lateral ventricle, and these ventricles are lined by the blood vessels which are referred to as the choroid plexus, okay. So these red things you see the choroid plexus, and these choroid plexus result in the formation of the cerebrospinal fluid. And once this cerebrospinal fluid is formed here, it travels within the ventricles to the various foramina, and then it finally escapes into the in these arachnoid granules just below. This is a dura. So if you take the meninges from inside outwards, this is a pia, then it is the arachnoid, and the outermost is a dura. So between the dura and the arachnoid, in that space, we'll have a lot of villi or the granules, and within these granules, the arachnoid granules, the cerebrospinal fluid gets absorbed. Okay, so formation is from the choroid plexus of the lateral ventricles, and the absorption takes place in the arachnoid granules, and before that it travels through a lot of foramen so that it covers the whole of the brain and spinal cord, the complete area it covers, and gets drained into the arachnoid granules. So this is again summarizing: choroid plexus, formation in the choroid plexus of the lateral third and fourth ventricle, and absorbs in the arachnoid villi of the dural venous sinuses. And this is the elaborate pathway that starting from the lateral ventricles, finally it gets drained into the arachnoid villi, and in between it traverses to the foramen of Winrow, cerebral aqueduct of Sylvius, to foramina of Luschka and Magenda. These are various pathways, the complete pathway where the CSF traverses and then ends up in the arachnoid villi. Now coming to the composition of the normal CSF, this is just the normal values which we need to know. I will be telling in detail again when I come to the lab investigation. So this is there in all standard textbooks. So please memorize it, write it down, that what is the normal values you see in the CSF. Okay, so the total volume, the opening pressure, the appearance, the cells, the glucose, protein, oligoclonal bands, chlorine and bilirubin. So this is a normal value. I'll be telling more in detail in my subsequent slides. Now, as I already mentioned, the function of CSF, it acts as a shock absorber. It supplies the nutrients and removes the waste products from the brain and the spinal cords. Okay. Now, before going into it, so now we have seen how it is formed, how it is absorbed, and then what is the function. Now, how do we collect the CSF? Okay, assuming the indication, the person comes with certain indication, and we are supposed to do a spinal tap or a lumbar puncture. So first of all, after obtaining consent from the patient, next thing which we do is we put the position in a lateral recumbent or a sitting position. So this is a lateral recumbent position where you make the patient lie down on one side and completely flex him. That is, you bring the knees to the chest and you bend the head towards the chest. It's like he's in a C position, complete curved position. That is what is referred to as the lateral recumbent position. Now, why do we put the patient in this position is because we need to open up the vertebrae. Okay, so we need to get put the needle at the level of L3 and L4 or at the level of L4 and L5, and this is a place exactly where we can go reach the subarachnoid space and take up the fluid. Okay, now why do we choose this is because at the level of T2 the spinal cord ends, it results in the formation of chorda equina and then other loose hair which is referred to as the phylum terminale. Okay, and we do not want to damage the nerve roots, and that is why at this space, because of the very sparse spinal roots which are present, we go and hit at the level of L3, L4 and L4, L5. So this can be achieved in a lateral recumbent position or in a sitting position. So definitely you'll be seeing this procedure when you go to your ward postings in medicine, and and when you are an intern, you will also be allowed to perform this procedure. It's a very commonly done procedure. In any case, I'll tell you about the indications, like especially in case of meningitis, very routinely done investigation. So you first make the patient, that is position. Next is you clean with the betadine. Nicely you would, after cleaning it, then you make it, drape it. You take a central hole towel and you place a hole at the level of L3, L4, L4, L45, and then you give a local anesthesia with 1% lignocaine. You infiltrate the skin and subcutaneous tissue, and then you take the spinal needle. So this is just a picture showing you so this is where the spinal cord ends, okay, at the level of L3, L4. So at this point it's very sparse, the hair roots or the spinal roots. That's why we perform it over here. So this is the CSF needle or the lumbar puncture needle. The stylet is removed. But the stylet goes inside this, okay, the plastic thing goes inside it. This is the needle. So this is what we get into, put it inside the patient. So at the level of L3, L4, you insert the needle, and once after you reach the subarachnoid space. So from outside to inwards, I told you there is dura, there is arachnoid, innermost is the pia, okay. So after you reach a subarachnoid space, you will feel when you cross the arachnoid, you will have a giveaway feel, as if something, loss of resistance will be there, which means you have reached a subarachnoid space, and it is at that space that once you reach there, and you remove this plastic stylet, you'll feel little drops, like small drops coming out, which means you have reached that is the cerebrospinal fluid leaking. So this is the various layers which you go when you're performing it. So once the fluid starts dropping, what we do is we collect the sample for the analysis. Okay, so basically you make use of 4 tubes. One tube is for chemistry, where you go do the glucose and protein examination. Also you can do the serology. Second tube is for the microbiology, where you do the various tests like gram stain, AFB, inulinic preparation, bacterial culture, fungal culture, and also culture for TB. So basically gram stain, AFB, and other various cultures. And the third tube is for hematology, where you do the total cell count and the DC count. And the last tube is for special studies like cytology and immunology. So you have taken out all the samples, okay. Now, and I've told you how to do. So now let's see the conditions wherein you are asked to do a lumbar puncture or a spinal tap, okay. So first is for the examination CSF for diagnostic purposes, that is especially in case of meningitis. So say a patient comes with high grade fever, neck rigidity, papilledema, all these symptoms, okay, and you're thinking in lines of meningitis, okay. So at that purpose of time, it's very important that you do the CSF and put the patient on antibiotics or antivirals depending upon the cause. So you don't need to identify what is causing the meningitis, okay. So for that diagnosis of the thing, you can use it. And then in certain other cases like hemorrhages, subarachnoid hemorrhages, which cannot be diagnosed by an CT, so in those cases you can do an LP. So it's for diagnostics, for diagnostic purposes you can do a lumbar picture. The second is therapeutic, that is to reduce the CSF pressure in benign intracranial hypertension, or it's called as a pseudotumor cerebri, okay. So because of the raised ICP, you put in the needle and you draw some amount of fluid and you bring down the pressure in the spinal pressure, so that to prevent the herniation of the brain. So this is the second indication. Third indication is administration of medications, okay. So introducing into the epidural or the subdural spaces, epidural space is referred to as the intrathecal medications. Many medications can be given, like first of all the anesthetist, okay. Anesthesia, that is you have your spinal anesthesia, okay, very commonly done for C-sections or any below abdomen surgeries, okay. So for that we make use of, we can give an intrathecal injection. Second is you can give steroids, intrathecal steroids, and third is chemotherapy, okay. So these are the few medications which are given intrathecally, which are very useful. The next is for the introduction of radiographic contrast or myelography, okay. So if you're suspecting a mass lesion, okay, so just like we use dyes in various other things, like intravenous spinalogram or a CT, or wherever you need, you inject a dye. Similarly, to examine the spinal cord, you can inject a dye and you can study, and that is what is referred to as the myelography. And then one of the other tests, which is the Quicken test, which we correlate to the JVP, but it's quite obsolete now. We really don't do the test much. So this is a myelography where you can see the dye is injected. This whitish area is completely the dye, and only at this portion you can see there's some kinking, which means that here there's some pathology. It could be a tumor, or we really don't know what is the pathology. We need to work further, but at least at this point of time we know that the pathology is somewhere here, and that has been identified by the myelography stains. So emergency LP is done in the case of suspected meningitis. Like when the casualty patient comes, immediately we do an LP to go in for diagnosis. Suspected subarachnoid hemorrhage, and also in cases of leukemia with the meningeal involvement. Now what can be the complication is if the puncture, if CSF fluid is looped, it causes hypotension, causes a post-puncture headache, which is quite severe. Or if you have not adequately cleaned the area, or procedure is not good, you can introduce some infection in spinal canal, which is very dangerous. Okay, and then they can be also, because of hematoma, traumatic, you can cause subdural hematoma or dry tap. That is, if you have not got any material at all, you have not reached the proper location, or you have misplaced the needle somewhere else, it can cause dry tap. And if lot of amount of fluid is drained, sudden, it's so much of fluid you drain it, it can cause herniation of brain. Okay, and also on the skin level you can cause a subarachnoidal epidermal inclusion cyst. So these are the various complications of lumbar puncture. Now where contraindications where you should not do a lumbar puncture is when the patient is having raised ICP. Okay, so don't perform because it can cause herniation of brain. Second thing is, if the patient is not stable, is having a cardiorespiratory compromise, or the patient is having certain bleeding diathesis or a localized infection at the level of L3, L4 or L4, L5, then do not perform a LP. So once the fluid CSF is drained, next you go send it to the lab. So it has to be sent in the glass bottles, and immediately it has to be sent. The CSF report typically should be given within 1 hour by the pathologist. Okay, so because the delay can cause any delay to the lab, or the sample is sitting in the lab for a long time, all the cells can lyse and it can grow certain bacteria or virus because of this contaminations. Okay, so immediately the report has to be given and the patient has to be started on treatment. Okay, so as soon as the first thing which we do when we are introducing a needle into the CSF, we make note of what is the opening pressure. Opening pressure is nothing but the pressure inside the CSF, in the cerebral spinal, in the spinal canal, in the cerebral spinal fluid. So your manometers so near the needle, end of the needle, you inject a manometer and you note down the opening pressure. Okay. The next is, after you draw the sample, you look at the appearance. So generally CSF is clear and colorless. Okay, but there are various abnormalities, like it could be turbid, it could be red, orange, xanthochromia, where it is yellow in color. So various colors indicates various pathologies. Okay, so appearance of the CSF is the second thing. The third thing which we do is we take the fluid and you do the total count. Okay, total count of the WBCs and RBCs, and also of WBCs we do the differential, that is to identify which type of leukocyte is more. Then next we go in for chemical examination, where we examine what is the normal amount of protein and what is the normal amount of glucose present in the sample. And last of all, we go in for microbiological examination when we have confirmed there is meningitis and we want to know what strain is causing it. You do a culture and sensitivity to identify the organism present in the fluid. And special investigations, which includes presence of some oligoclonal bands, which are seen in conditions like multiple sclerosis or Guillain-Barré syndrome. In this, we try to identify the special proteins or which are present in the cerebrospinal fluid. So I'll tell in detail in subsequent slides. So opening pressure, as I mentioned, the normal limit is around 60 to 180 in adults and 10 to 100 millimeter water in children. So as soon as you put in the pressure needle, put in the manometer and check for the pressure. So certain cases where there's increased CSF pressure is the patient is very tense or anxious patients. There's a mass lesion in the brain, in the pathway in the spinal cord of brain, meningitis, cerebral edema, subarachnoid hemorrhage, congestive cardiac failure, and benign intracranial hypertension. All these causes an increased CSF pressure. Decreased CSF pressure seen in traumatic or in complete spinal block. And the gross appearance, I told you it is very clear fluid, okay? It is a clear colorless fluid without any clots. So the various other abnormal fluids which can be seen are, it's the turbid CSF, it's a blood mix, xanthochromia, which means it's a yellow color CSF, or there are certain abnormal colors like pink, brown, clot formation, or this thick viscous. So these are all abnormal formation appearances of the CSF which indicate certain pathologies, and further investigations have to be done. That is, you go in with a total count and then you go in for the microbiological examination. So I'm going to skip this slide because it's not much. That is, if it is a blood fill, that is the CSF appears bloody, then we need to know whether it is traumatic lumbar puncture or it is due to subarachnoid hemorrhages. So this is not in detail, I'm not going to explain to you, but this is there is a procedure to identify it. Now next, coming to the cell count. So you identify the total leukocyte count, and it is done in a chamber called as a Feucht-Rosenthal counting chamber. So this is a modified Newmar's chamber. The only thing is the depth of this chamber is double when compared to that of the Newmar's chamber. So that is why we make use of the Feucht-Rosenthal counting chamber, and ideally we use an undiluted sample because the sample is very less and generally they don't have much of cells, okay? So only if it is more cells, very turbid, then you use a diluting fluid like a Turk's fluid, or you can just choose an undiluted sample and then you can count. So in the squares, I will tell you. So this is just a picture showing the Feucht-Rosenthal chamber, and for the WBC you count in the WBC squares, and for the RBC in the RBC squares. The 5 RBC squares you will count it and give the values. Also, you will do a differential count, that is, you will centrifuge the sample and the cell button. You will take it and put it on a smear, and then you will stain it with a Romanowski stain. And you can also make use of Leishman or HNE, but depending on what you want. And then you will try to see which is the differential, that is, which is more lymphocytes or neutrophils or eosinophils, and also if you're seeing any other cells like malignant cells, anything is seen in that. So you will do a DC and then a total count and DC on that particular sample. So this is a picture, this is just showing, this is a tableau column showing what are the different cells which can be seen, and if present, what do they indicate. So if there are neutrophils, think of meningitis. More of neutrophils, think of meningitis, especially bacterial meningitis, very rarely viral fungal, but many neutrophils means it's meningitis and bacterial meningitis. Other conditions where you can see neutrophils are subarachnoid hemorrhage, repeated lumbar punctures, anti-cancer drugs or contrast-induced meningeal metastasis. Lymphocytes, think of meningitis, always think of viral or TB meningitis. Other things are cysticercosis, toxoplasmosis, multiple sclerosis, SSPE. A mixed pattern where you can see lymphocytes and neutrophils, think of TB or fungal meningitis. And eosinophils are typically seen in parasitic and fungal infections. So after finishing the cell count, then you can also proceed on to do the chemical examination where you estimate the proteins and glucose. So normal protein limit in a CSF, it's around 15 to 45 milligrams. This is normal amount of fluid. So how do we assess this? We make use of the turbidimetric method. Pandes is obsolete now, but we make use of turbidimetric method, and with that we assess the proteins. So where do you see increased proteins in the CSF is increased capillary permeability of the blood-brain barrier, example meningitis, okay. So you know there is a blood-brain barrier which prevents unnecessary cross movement of the molecules, okay. So whenever this membrane is damaged, okay, and it causes increased permeability, it is in conditions like meningitis. So any case of meningitis, you will see increased CSF protein. If there is a mechanical obstruction to CSF, as in like there's a tumor, it's obstructive, which causes increase in the proteins of CSF. Increased intrathecal IgG production, that is certain cases in which this production of the immunoglobulins, and this will raise the viscosity. In IgG is also a protein, so this will raise the viscosity, and that will cause increased CSF proteins. Examples: multiple sclerosis. Conditions where there is both increased capillary permeability and increased IgG, like Guillain-Barré syndrome, or there is a hemorrhage in CSF. So these are the causes where there is an increased CSF proteins. Glucose. So now glucose, the normal level is around 45 to 80, and it is determined by the glucose oxidase method. So any abnormality in the CSF, the glucose will decrease. You have to remember proteins will increase and glucose will decrease. So where all you see a decrease CSF is, you see it in meningitis, especially in TB, bacterial and fungal meningitis. You will see a reduced glucose levels. Other conditions is in the patients having hypoglycemia or in meningeal carcinomatosis, okay, which means the carcinoma has spread to the meninges. So now this is a very important tabular column, like the important slide of the whole class. So you need to know, very frequently asked question, what is meningitis? What is the CSF picture in different types of meningitis? So this is very important. So you know this is a normal condition. So normally CSF is clear. It has less than 5 cells, and even the 5 cells could be mostly lymphocytes. The proteins are 15 to 45, which is the normal level, and glucose is 45 to 80. This is a normal CSF. In meningitis, there could be 3 etiologies. One is it could be bacterial meningitis, or it could be TB meningitis, or it could be viral meningitis. In bacterial meningitis, the CSF appears turbid. It has increased WBC, like it can be more than 1,000, and especially more than 90% of them are neutrophils, okay. Protein is also increased around 50 to 1,500. The glucose is decreased, it's less than 40, and depending upon the organism, you can do a gram stain and you can also do a culture, okay. So identify what organism, whether it's gram positive, gram negative, and based on the culture we can identify what is causing the meningitis. The next is a TB meningitis, in which the CSF is clear or cloudy, and again WBC is increased, but in here there are more number of lymphocytes. Again, if you see, it's not marked increase, around 100 to 600 the WBC will be increased, and predominantly we'll be seeing lymphocytes, but some neutrophils can be noted, okay, but it's like a mixed pattern, lymphocytes and neutrophils, and proteins are again increased in here, 45 to 300, and glucose is decreased. And to confirm it, you do an AFB stain, and it can be followed by a culture, and then you can also do a PCR. So this is a picture you see in TB meningitis. And last of all, viral meningitis, you can see it is clear or cloudy, and it is increased but not very significant, like 300, okay, and everything is lymphocytes. So typically only lymphocytes will be seen. Proteins are again increased, but if you see over here, the glucose is completely normal. And for for additional investigations, for confirmations, you make use of a PCR. So this is the important slide of the class today, where you need to know in various meningitis what is the CSF picture. So moving on to the next slide, after we have done the counts, the chemistry, and I had also given you note on the meningitis, various meningitis. The next which we do on the CSF is a microbiological examination, where first we can do a direct wet mount, and it helps in identifying organisms like Trypanosomiasis, Candida, and Cryptococcus. So this is a picture where we can see the flagellate trypanosomes, like curvy, wavy structures. So on a wet mount you can do, and this is the hyphal forms of the Candida, where you can see the fungal hyphae, and this is Cryptococcus neoformans, which are round structures, and they have a capsule, thick capsule around it, which can be seen in Indian ink or also on the fluorescence. So the round structures with a fluorescent capsule. So these are the things which we can identify in the microbiological stains. We also do a gram stain, and the gram positive organism which we can see is pneumococci. If it is gram negative, think of H. influenza, E. coli, and meningococci. And this is a picture showing gram positive cocci. You can see all these are the blue structure, the gram positive cocci. And this is a neutrophil. These are the nuclear lobes. These are nuclear lobes, and this is a neutrophil. So extremely small structures here are the gram positive cocci. The other stains which we can do are the Ziehl-Neelsen stain, lattice agglutination, serological test for syphilis, and then you can also do a culture to identify which is it. And last of all, you can always do a PCR if the viral load is very less. So this is a Ziehl-Neelsen stain, where we can see the acid-fast bacilli here as long rods. This is the rhodomine stain, the fluorescence again to pick up the acid-fast bacilli. So all these are the fluorescent bacilli. The special investigations which can be done is a protein electrophoresis to identify the oligoclonal bands. So normally in plasma you can see this oligoclonal bands, but whereas in CSF will be absent. But in abnormal cases like in multiple sclerosis, both in the CSF and in the plasma, you can see this oligoclonal bands. So this protein electrophoresis helps in identifying the lesion, okay? So identifying the what pathology, what the patient is suffering from. So these are the special investigations which can be done on CSF. So that finishes the class. To summarize, CSF, first you should know the formation and the absorption. Next, you should know what are the indications. Third, you should know how to perform the procedure. Fifth is, once you get the procedure, how do you collect it and what are the various investigations being done. And last of all, a note on meningitis and a CSF picture in various forms of meningitis. So that's about the class today. Thank you.